Hello, good evening, good afternoon, good morning. I don't know in which part of the world are you, but it's afternoon in Poland. I'm drinking my afternoon coffee, so cheers to you. Uh, my name is Bartlomiej, and I have a very big privilege and a pleasure to have a webinar with you. It's my fourth webinar for the Poland company, but the first one in the English language, not the first one in my life, but the first one for the company, for the brand Endastar. So I'd like to say hello. First of all, I would like to tell you a few things about me and the company, why I am talking to you, and then I would like to tell you some things about the shaping of the MB2 canal in the first upper molar. So, in the very beginning, I'm talking to you because I'm a practitioner, I'm also a lecturer, and I'm working with the Poland for a few good years. And I'm not working with them because they pay me, but I use the E3 Azure files on the daily basis in my everyday practice, and these are the files which I like the most. I perform like 80% of cases with these files, maybe even 90, I don't count it, but these are the main files in my Endo box. Of course, I sometimes use other files. As I mentioned, 80-90% it's E3, so it means that 10 to 20% there are other files, but mostly my daily file is the E3 Azure. So I believe that I can tell you quite a lot of interesting tips and tricks how to use these files, and for sure why I am happy and satisfied with all the idea of the E3 Azure. So I will now turn into my presentation, shaping of the MB2 canal, which should appear right now. I'll just wait a second for the confirmation. Am I right? Are you seeing this good? Sometimes I need like 10 or 15 seconds of the break because there is a kind of lag, and I need to ensure myself is everything okay? Are you seeing everything? Is everything right? So I'm waiting for the confirmation. Everything is perfect. Okay. So, ladies and gentlemen, the MB2 canal is the one of the most important canals in our endodontic treatment, because this is very tough canal to shape. And one more second, I need one more second. Okay, because this canal is mostly hidden, and we have to not only shape it, but first of all find it. And I will not talk to you about discovering this canal, but I will tell you about the next step, which is the shaping protocol, which is very important. And first of all, I will tell you some things about the files, then we will talk about the morphology, and then we will talk about the case and the protocols. So, first of all, the files. Well, most of all, in most cases, I like the less number of files that is available in the situation. Which means that if I can use only one file, I will use only one file. If I'll need 2 or 3, okay, I'll use it, but I'll try to use as less as it is possible. And why for me the E3 is a good choice? First of all, we have 9 different files to choose, and we can choose 1, we can choose 2, we can choose 3, sometimes more, very rarely, in very rare occasion. But in situations like MB2, you will see my sequences, and you'll see that I use usually two or three files from the Azure sequence. And what is very important thing for me is that the most common files are like around number 25, the single file systems or two file systems. Most of all, they are 25, sometimes maybe 20, 22, 23, something like that. It depends which brand is available on your market, because it varies around the world. But most of all, there's something like 2508, 2507, 2506, or 2505. These are the most popular, I believe. At least on the tip, because it can change. So now, if we're talking about the canals that are double or triple curved, that can be very long, or the root can be very specific, we need smaller files. Not only the hand files, but sometimes, maybe not even sometimes, in many occasions, many cases, we need the files like 2006, 2504, which are very important during our shaping protocol, and you'll see it later. So the E3 Azure sequence is very good for me, because in like 90% of cases, or even maybe even 100% of cases, I start with 2506, and then I make some decision protocols which allow me to do the best shaping I can. So you'll see the sequences later, because to understand the sequences, it's very important for us to understand the anatomy and the morphology of the mesial root. So let me go to the next step, which is the movement of the file. And the manufacturer says that you can do anything you want with the E3 Azure file. And this is, for me, this is very good situation, because many manufacturers tells us that no, please don't use it in reciprocation, or we have been testing this one in reciprocation. We have the reciproc or wave 1, which are the reciprocating files, but they are turning counterclockwise, so you are not able to use it in very many endodontic motors, so which means that even if you have a good file on your market, even great file on your market, when you're not buying the dedicated endomotor, endodontic handpiece, I mean, you're not able to use this file. So this is not a good situation. And if you see on the slide that you have now, you can see that the manufacturer says that you can use it in rotation, reciprocation, and OTR movement, which is some kind of adaptive connected movement. There are different names for this one, but this is the, I believe, most advanced movement of the file right now, which is based on the continuous torque control. But I will not talking about the movements, but about the MB2, this is only mentioning. In most cases, I use the reciprocation, the clockwise reciprocation. This is very, very important to mention, that this is the clockwise reciprocation movement, not the counterclockwise like reciproc or wave 1, because the file will be not cutting. Short break for a sip of a coffee. And we can go to the morphology. And the main question about the morphology of the mesial root is, does the size matter? You can see on your left side of your screen that you have some slices of the mesial root of first upper molar. And there's very big difference of the amount of dentin that is available around the MB1 and MB2 canal. Please see the part of the root, the palatal part of the mesial root, where the MB2 is located, and see the huge difference between the dentin that is available around the MB1 and the MB2 canal. So if you are shaping the MB2, I believe that you shouldn't, or we shouldn't use such large the tapers and files as we can use, for example, in the palatal canal or even MB1, because if you are talking about the canals, we are not able to say that the MB2 is the worst canal in any meaning, but definitely the root is thinner. So we have to think also about the dentinal structures in the root, which if you cut once, you're not able to bring it back. So if you do the shaping, you're not able to reinforce the root in any condition, in any idea. So if you will cut too much dentin once, you're never able to go back. There's no like Control Z or Command Z on the Mac. You're not able to go back. So you have to remember about this and not shape this root or this canal too much. So which means that if you have single file systems or files with only 06 taper, in some cases it can be too much. So this is the idea why I do like the E3 Azure sequence, because I can not only change the ISO, but I can also change the taper of my shaping protocol. And we'll see it later. And the size and the specific morphology of the mesial root isn't the only challenge, because the mesial root is very complex structure. And you can see it right now. This is all these images are from root canal anatomy project, rootcanalanatomy.blogspot.com. This is the page, the website from Professor Marco Versiani from Brazil. They have beautiful 3D images of the micro-CT reconstructions of human teeth. And you can see, especially on the right side, how complex this root is. This is whole net of the structures, of the pulp structures. This is very demanding space for shaping. And of course, we are not able to shape 100% of this space, but we can remember, we can and we should even remember that the shaping protocol is the beginning of the cleaning and is the first step, of course very important step, but it's the first step before the irrigation protocol, which is even much more important, but maybe we'll talk about it in some other webinars. Let's focus on the morphology of the mesial root one more time. This is the very well-known Vertucci classification from 1984, a very beautiful year, especially for music, but also for the endodontics. And there are four most common, most important structures which appear in the mesial root. Most of all, the type 4, which means that we have two separate canals, and the type 2. These are the two most common, but we cannot forget about the type 6, which means that the separated canals are connected with some kind of isthmus, or even they are joining the same place and they have two separated apex, and sometimes it's very hard to shape. And it can appear that when your instrumentation of the MB1 and MB2 goes like in a type 2, which means that you have common apex, you can also meet or have this additional, let's call it additional, but it's not additional because it's already there, but let's call it additional apex, which can be very challenging in shaping, or even which can be unavailable to be shaped. So the irrigation protocol becomes much more important even. And of course, maybe not the most common because it's the less common type, but very important, and the most challenging, the Bertolucci type 8, when you have MB1, MB2, MB3, and they can join, they can divide. This is very, very challenging. This is hell of a shaping. Okay, but for you to remember, the most important things is that usually we have type 2 or type 4, which means two canals with the common apex, type 2, or two canals with the separate apex, which means type 4. The next thing for you to remember is that there is very big difference in the amount of the dentin between the area of the MB1 and the area of the MB2 because the root the mesial root has big disproportion of the dentinal structures. So now you know the morphology and the Bertolucci, we can go step further. In many questions from my participants, I hear like where to find the MB2. Okay, ladies and gentlemen, there's around a lot of investigations, a lot of data, a lot of researchers. We have one very good tip. About searching the MB2, and I have a question from Sarah Dent. What do you think about selective RCT? Is it effective? Oh, Sarah, this is a very good question. Thank you for this question. But the answer is not so easy. Mostly I do the retreatment of the whole tooth because in most cases everything is connected, more or less, even in the pulp chamber, even if there is composite resin. After many years, I believe that the bacteria can go from one canal to another, nevertheless. So I'm not enthusiast. I do it in very, very rare opportunities. Actually, maybe I've done it like 3, maybe 5 times, maybe. But mostly I do the whole treatment. The first reason is what I already told, and the second one is look, maybe the treatment is working around the distal buccal or palatal canal, but if the previous treatment or the previous operator, previous dentist, surgeon wasn't able to perform good quality treatment for all tooth, how should I suppose to know that anything will fail later? So I don't like to do the part of the job. I like to do it all. I hope this answer is good for you. If not, let's talk later. Okay, let's get back to the tip how to find the MB2. The very good tip which works in 90% of the cases, and I believe when some tip works in the 90% of cases, this is a very good tip. And this tip is to find the groove. If you will find the groove, you can see it on the image. You have to follow the groove for next 2 millimeters from the MB1 orifice. And if you don't have the groove visible, you should go 2 millimeters along the mesial wall. And this is very big concern about this thing among the practitioners, because many practitioners say that you should go 2 millimeters to the palatal canal, in the direction of the palatal canal. No, if you will go 2 millimeters in the direction of the palatal canal, you will go more like, maybe I'll change my pointer. You will go somewhere here, and actually this is the furcation zone, so I would not like to be here. So you have to go 2 millimeters along the mesial wall, and in 90% of cases you will find the MB2. And as I mentioned, the searching of MB2 is completely separates the subject, so we'll focus on the shaping, but I have to make a short introduction to tell you where to find it. So here's the case, and then I will talk to you about the sequences. Here is a case of the irreversible pulpitis, or necrotic pulp, which was symptomatic, and in cases like this, I performed single session treatment. Many of you can ask, why do I perform the cone beam? Because this is not a complex case, there are no complications, this is not retreatment. Okay, my answer is that I do cone beam. I do the cone beam because, first of all, it is available in my clinic. This is, I believe, very important. Second of all, I do it for all cases during the consultation, during consulting my patients. And third of all, I believe that from the small field of view, which I do always small field of view for endodontics, this is the best one, the safest one. I can gain additional information. For example, you can see right here additional information that in I believe 90% of chances I can find separate apex, and this is good information for me before the treatment, because if I will shape the canals and during the shaping protocol will occur that I have instrumentation like type 2, which means in the common apex, I should know that something went wrong during my shaping protocol, because in 90% I'm certain that I need to have 2 separate apex, so I have to work harder. And Edmund Draksha has a question: what do you do for throgging? I'm not sure about this word. Can you explain me, please? And I will answer in 5 minutes. Okay, so the case was referred like this. We had to very big composite filling and the temporary material. And another question from Sarah: do you think that is the relationship between pulp pathology and finding MB2? Sarah, do you think pulp pathology, you think pulp chamber calcification, obliteration, something like this? Because if yes, I would say definitely, because if the pulp chamber has some pulp stones or has a big amount of dentin from the mesial wall, which was appositioned, so I mean tertiary dentin, yes, the finding of the MB2 will be much harder. But as I mentioned, searching and finding MB2 is additional topic, because it's hours of talking. So I have removed the pulp chamber roof. As you can see on the left side, the chamber of my first molar, it's not in the shape as it should be, because it's almost a line, or maybe half of the letter Z or something like this, and you can be sure that if the shape of the pulp chamber is like this, it means that the chamber is hiding something. Maybe this is a part of an answer for Sarah. Please look at the picture next to. I have removed quite a lot of dentin from the mesial wall because it was covering and hiding the isthmus I was talking 2 or 3 slides earlier. So which means that it was hiding our orifice of the MB2. So I had to use the ultrasonic tip and search for it and remove it. Then I was able to shape, and the first part of shaping after removing the dentin is to take my mechanical file, rotary or reciprocation, depends on you, and to make orifice opening. Some of the practitioners say it's like countersinking, which means that you're making the small spot for your hand files like 2 no more than 3 millimeters, and you make like shape like this, yeah, with the rotary file, because this is the tip of the rotary file. Then you have the straight line access to the middle part of the MB2 canal. And to be honest, at least half or maybe even 70% of the issues or problems with the MB2 shaping is connected with the coronal part, the orifice, because if you will not shape in a proper manner, I mean straight line or maybe 70% straight line, you will have many issues in the middle part of the canal, and you will probably perform a ledge, which is very, very hard. Okay, let's make a short stop, sip of coffee. Question from the Draman: if we leave or can't find MB2 and treat the teeth, what will be the prognosis? Okay, dear Draman, the prognosis actually will be like 50-50, because when you will have the Vertucci type 2, which means the common apex, there is a possibility that you will reach the success, because you will close the apex, you will close the chamber, and everything will be sealed, so there is a chance for success. On the other hand, many researchers and articles says that every part of undisinfected tissue, of remained tissue, infected tissue, can be a cause of the failure. So I believe we should find and shape it, because at least 90% of our cases have the MB2 canal in one of the 4 types. So this is pretty common. So I would say even that the finding, not only searching, but finding the MB2 is the mandatory thing during my treatment. Next question, that the Edmund's scrapping the dentin, Edmund the throgging, scrapping the dentin with something in search for MB2. Okay, yes, I use ultrasonic tips. I use ultrasonic tips with the diamond coating. Very effective for me. I have few brands, it doesn't matter. There are a lot of them available on the market, but as I mentioned a slide before, in this case also I did it with the ultrasonic tips. And Sarah, can metal and blue give some help? To be honest, I don't use it. Maybe it can, but it can be false positive sometimes. But I believe that the most important tip is to find the isthmus from the MB1. If you will find it, you will find the orifice, and you will find the orifice, and you shall the MB2. I was reading also another question: what if we over instrument the canal? Dear doctor, this is a very good question, and the answer is not very good for us, because first of all, you can do a strict perforation, or there can appear a vertical root fracture from the tip of the root, I mean from the apex, so which means like 99% extraction. So this is not good. Okay, let's go, because I have some more things for you to say. And this is the view of the chamber after cleaning and shaping protocol. You can see that the shape of the chamber has changed. Now it looks like typical chamber, almost typical chamber of the first upper molar. Maybe this place here has just a touch of too much of dentin, but it doesn't it doesn't matter because we have shaped 4 canals, MB1, MB2, distal buccal and the palatal below the wall. So we have proper shaped upper molar. And I would like to show you one more thing. You can see here just some kind of dentinal roof, and I didn't like it, so I removed it with the ultrasonic tip, but there was nothing, as you see on this slide. You know what? Another question from searching the MB2. Actually, you know, I will talk with the girls from the Endostar, and I believe I will perform webinar about searching the MB2, because as I see, we have much more question about searching than shaping. So I believe I will show you much more because the answer for your question, dear Edmund, is not so easy because many things depend on this. If this is primary treatment, secondary, what is the angulation of the root? There is no such an answer when I'm giving up. So I believe it will take like 20 or 30 minutes to talk about giving up. I believe so. Okay, so we have some sequences, but I would like to summarize the earlier things. First of all, the morphology. Remember, of the 4 Vertucci types, the 2 of them are most common. The type 2, which means the common apex, and the type 4, which are two separated apex. Sarah, do you prefer manual or rotary file? This will answer your question. This schemes. So 4 types, the 2 of them are most common. Remember that there is a big MB1, big amount of dentin about the MB1, and around the MB2 there is not much dentin around, so be gentle. You have to know that in 90% of cases, the MB2, the orifice of the MB2 is around 2 millimeters from the orifice of the MB1 when you are going next to the mesial wall, not to the palatal canal. And for the shaping of the MB2, we have to be very gentle, and now you have the sequences. Okay, so first of all, when the MB2 is pretty short, it's like 17, 18, maybe sometimes 16 millimeters, I prefer to do some sequence like this. The first rotary file is 2506, as like here and here, so which means the other file with 2 red stripes. And in the very beginning, as I've seen, as I've shown you before, I use ultrasonic tips to remove this part. Yes, this roof or head, depend how you call it. Then I can go and I prefer to maybe just to scout with the manual file, but I'm not, maybe not scout is not even the good word, just to check if the first piece of the canal is patent. If it is patent, I can go with the rotary file, but please do not go too deep with the hand files, because you will stuck around here. You'll make a ledge, and there will be a huge problem. So as you see, you can go just in the coronal curvature, maybe with your small hand file, and then you can go with the rotary or reciprocating file, and to shape the coronal third. This is very, very important. I believe I do it in like almost 100% of cases, but in MB2 this is even much more important. And then if you have the straight line axis, if your rotary file shaped you very good quality orifice, then you can go deeper. And of course, it depends. Sometimes it is the K file number 15, sometimes this is K file number 10, or even K file number 8. It doesn't matter for me at this time. This is not the most important, but the most important is to go up to the K file number 15 and then take one more time your rotary file or reciprocating, let's call it Azure. You take your other file 2506 and then you can go to the apical third, and in the very end of the shaping, remember about the patency. Of course, among every file, or after every file, after every piece of the mechanical instrumentation, you have to flush it with the sodium hypo to clean the canal space and clean the fluids of the file. This is very important. Then, if your working length is like 17, 18, maybe sometimes 16 millimeters, maybe the MB1 is the MB2 is joining to MB1. There is good enough for us. You don't have to go with another files. But if the working length is like more than 18 millimeters, like maybe 20, maybe 21, 22, or 24, even sometimes, you have to remember that the amount of dentin around the furcal area is limited. And this is the thing which I mentioned in the very beginning. When you are using the 06 taper file in the long canals, more than 18 millimeters working length, you can pick too much dentin or scratch too much dentin from the danger zone, and you can go with the strip perforation. Sorry, I forgot the word. The strip perforation. So this is very important to switch to the smaller taper. You can go with the same ISO, but you need to switch for the smaller taper. I mean taper 04. And in the same manner like the sequence before, you can go with your file number 15. Sometimes you can switch to 10, or sometimes you need to switch to 10. So everything depends. But finally, before using your other file, you need to reach the hand file number 15 for the glide path. Sometimes when the canal is curved, double curved, I mean S-curved, or very long or very narrow, you need to use 2004. And after 2004 you can go 2504, or sometimes if the 2504 you check the fluids after the instrumentation and there is not a lot of dentinal debris on the tip of the file, you can go with 3004. 3504, okay, I sometimes do, but usually in the retreatment cases or cases when my K file number 15 was very loose, which doesn't appear in MB2 too often, to be honest. Ladies and gentlemen, thank you for the MB2 shaping protocol. If you have questions, please ask me. I'll talk like a few things more, so you can ask questions now. Of course, we'll summarize everything and I'll ask questions later. But from this place, I would like to invite you for the Tuesday, the 21st of the April, for a beautiful lecture from Jorge Eduardo Gaviria from Colombia. This lecture will be available in 5 p.m. Polish time, which means Central European time, and 10 a.m. Colombia local time. You have to check it where Jorge Eduardo will talk to you and what hour in your country. Sarah, another question. Do you use EDTA gel in beginning of management? Sarah, to be honest, no. I use EDTA liquid or sodium hypo liquid because gel in the very beginning is ineffective, in my opinion, because it's not liquid, so it doesn't float inside the very, very small, tiny isthmus or orifice. So I prefer liquids at this stage. Eduardo, do you prefer recapitulation with Patency file, yes, I do it. I do it all the time. Maybe I'll go back to the sequence. Let me show you that actually this file is, let's say, the recapitulation of the patency file and also the glide path file. And this file is also the patency file and the glide path file. And definitely this is the patency file in the very end. I use it. I use the K files, usually number 10, sometimes 15. It doesn't matter. Okay, another question, Jenk Tahiri. Do you reuse the files after autoclaving? If yes, how many cases you throw it away? Jenk, very good question. Thank you for this question. In the case of the Azure files, this is very easy. I, of course, reuse the files, and I'm okay with that. And I throw it away when the flute of the file is screwed or unscrewed, and it doesn't. It's not similar to the new file. If I have any doubts, I take a new file from the blister and I compare it. When they look the same, I use it, reuse it. If they are not looking the same, I throw it away. So this is very good indication. Sarah, obturation technique for narrow canals. Dear Sarah, I'm a huge enthusiast of CWO, which means continuous wave of obturation, the Steve Buchanan's technique. When you shape the coronal and the middle third with O6 taper, there are no narrow canals for CWO, I believe. At least not for my shaping protocol. We'll go back. Why? Because you can see I've done the protocol with 2506 and 2504, and please look at the apical area. Everything is beautifully sealed, so I believe this is great. Okay, so if more questions will appear, I will of course answer. I would like to say thank you very much. You can find me on Facebook. You can write email to me, and then I will answer your questions. No worries. Let's go and write. Let's go and talk. I love to talk, so we can chat about the endodontics. Okay, I have just one thing from the girls from Endostar. Yeah, definitely. Many people are watching all around the world in different times, so I believe the questions will appear also later. So I would like to mention that we gathered here thanks to the Endostar E3 Azure brand. So say thank you to them for the lecture, most of all, and I had a huge pleasure to talk to you. Unfortunately, I'm not able to see you as you see me, but I was reading all the questions. So thank you very much for your activity. Take care, have a good weekend, and most of all, stay safe. Thank you very much.